Hello students, today we'll discuss an interesting topic. Mostly it is important in theory, rather short note may ask, and MCQs it is important. A lot of things are there in this very compact topic. A lot of MCQs can be asked, which we need to remember. And much more than that, it's very interesting also. Topic called as MEN syndrome, otherwise multiple endocrine neoplasia syndrome. So many endocrines are involved, neoplasm occurs, and variable presentations can occur like pituitary, parathyroid, pancreas, sometimes adrenal, thyroid, and so on. So many endocrine glands are, almost all major endocrine glands are involved in this syndrome. That is why it is important. And this MEN syndrome, initially it was called as MEA syndrome, multiple endocrine adenomatosis syndrome, maybe in 1950-54. Eventually it is named in 1968 as multiple endocrine neoplasia syndrome. And actually this term concept has started almost more than 100 years ago. 1903 this concept has come, but it is eventually concept have developed and reached a present form over the span of 80 to 90 years. So current terminology is multiple endocrine neoplasia syndrome, which is equivalent to or same as older terminology, which is not used currently, is MEA syndrome, multiple endocrine adenomatosis syndrome. Both are same, but right terminology or current terminology is not MEA, it is MEN syndrome. So this is what exactly I told, MEN syndrome, multiple endocrine neoplasia syndrome. Rather very interesting topic. So it is endocrine syndrome, complex usually. It is inherited as autosomal dominant. That is also important. Could be due to inactivation MEN type 1 tumor suppressor gene. Mainly type 1 gene is 11. That is important. Again, MCQ may be asked. It can be sporadic occasionally. Commonly, it is inherited, autosomal dominant, not recessive. It's a mutation of RET. RET full form, just remember, often asked as a MCQ. Rearranged during transfection. And proto-oncogene MEN type 2 is chromosome. MEN type 2 is 10. MEN type 1 is 11. 1 is 11. 2 is 10. MEN type 2. This is the MCQ question which you have to remember. And so I'll just put into the tabular form. MEN type 1 is called as Werman syndrome. Again, often asked as MCQ question. Spelling, remember, WERMER syndrome. Wermer, not Werner. There is a syndrome, another syndrome, Werner syndrome, WERNER syndrome. That is genetically related early aging. Beyond puberty, at the puberty they start developing aging. So totally it is due to genetic mutation, DNA mutation probably. There are so many causes are there. Osteoporosis, early aging, diabetes, they develop everything. So their life expectancy is very low, less than 40 or around that. So that is Werner's syndrome. So spelling is important. That is different. In MEN syndrome type 1, it is Wermer's, WERMER. It is MER syndrome. So 3 P's are important: pituitary, parathyroid, pancreas in type 1. Defect is in chromosomal number 11, subdivision Q13. It's a menin related. It's again MCQ question. More often familial, already told. Autosomal dominant, again important MCQ question. 50% of chances transmitted to the disease next generation. So next generation, children, grandchildren, it is transmission is very, very high in Wermer syndrome. 3 P's, 3 major main pituitary or main organs involved is 3 P's: pituitary, parathyroid, pancreas. And again remember, thyroid and adrenals are not commonly involved in type 1 type. That is a difference. So pancreas, pituitary, parathyroid. So pituitary, parathyroid, pancreas, if you remember from above downward, pituitary, parathyroid, pancreas, but no thyroid, no adrenal. So that's what you have to remember. Whereas type 2 is different. Main content is MCT, medullary carcinoma, thyroid. Pheochromocytoma is very common. parathyroid hyperplasia in type 1, 3P, 2P plus 1M. So parathyroid hyperplasia, pheochromocytoma, medullary carcinoma thyroid. So naturally calcitonin level will be increased. Or see the type 1, type 2A, MEN type 2A, or mucosal neuromas in the lips and eyelids with the bumpy, lumpy lesions, morphonoid phase, congenital megacolon. This is type 2B. So this is the A, that's why I put OR here, type 2B. So that is actually called MEN type 2 mucosal neuroma syndrome. It is often also called as name which many people don't know. This type 2A is called a simple disease. All of us aware of that. Type 2B has got a syndrome name actually. Most of us don't know that. Wegenmann-Frobois syndrome. Wegenmann-Frobois syndrome is the name. May be asked as MCQ. So type 1 Werner's syndrome, not Werner's. Type 2A is simple disease. All of us know that. Type 2B is mucosal neuroma syndrome, also called as Wegenmann-Frobois syndrome. Wegenmann-Frobois syndrome. So remember type 2A, chromosome 10, I already told. MCT, pheochromocytoma, parathyroid hyperplasia, 1M plus 2P. Here 3P, here 1M plus 2P. Where type 2B, medullary carcinoma thyroid, mucosal neuromas in the lips and eyelids with bumpy, lumpy lesions. That is peculiarly or popularly called as bumpy, lumpy lesions. Morphonoid phase, amyloid deposition in the skin. It's quite known entity. Congenital megacolon. That's also common. Pheochromocytoma in MEN is almost always benign, remember. Whereas MCT is malignant, remember. Medullary carcinoma thyroid is malignant. Pheochromocytoma is benign, but can be functional. That is important. It can be bilateral. It can be functional. Multicentral, it can be functional. So we need to do the noradrenal derivatives like VMA, metanephrine, all those evaluation in the markers, evaluation in the serum has to be done in such patient along with the MIBG scan or MRI or CCT abdomen. MEN2B is more aggressive, remember, this type is more aggressive, commonly seen in younger age group, in infancy and early childhood. So RET codon here is 634 for MEN2A, RET codon is 918, difficult to remember, but it is often may be asked as MCQ in your NEET exam in the due course of time. In that point it is important, otherwise you can always refer and find out what exactly codon is. But this codon may be asked as MCQ. So that is the reason you may have to remember when you face a NEET exam or entrance exam. So simple, remember Werner's disease syndrome, simple disease, Wegenmann-Frobois syndrome, MEN1, MEN2A, MEN2B. So 3 types, 1, 2A, 2B. Werner's syndrome, simple disease, Wegenmann-Frobois syndrome. So this chart gives a very clear idea what exactly meaning of each. Little more discuss. This is more than, this table is more than sufficient for undergraduate to recapitulate, realize and write short note and express. Little elaborately you can express once you know this table very clearly. So you memorize this table, you'll be able to write whatever you need, you'll be able to face the MCQ. Little more detail we'll have a discussion, so that we'll have a understanding in a better way. So type 1 I already told, first component is hyperparathyroidism. I said parathyroid, pituitary, pancreas, endocrine tumors actually. Neuroendocrine tumors of the pancreas. Naturally they are arising from the endocrine glands. Pancreas has got exocrine gland and endocrine glands. Exocrine secretes all those enzymes for digestion, amylase, trypsin, chymotrypsin, and lipase, elastase, collagenase, all those things. Here it is endocrine tumor, endocrine cells. They secrete insulin, glucagon, gastrin, gastrointestinal polypeptide, pancreatic polypeptide. So many things are there. They are pancreatic endocrine secretion. They are endocrine secretions directly into the circulation. So hyperparathyroidism is the first commonest component, main component. 90% it is seen. It's due to parathyroid adenoma or hyperplasia, not common carcinoma. But most important is occurs in younger age group. So at the age of 20, they present with the symptoms. Definitely, they will have all symptoms at the age of 40. So 20, they begin with the symptoms. So early, you'll be able to diagnose all features of hyperparathyroidism. I am not going to discuss. We know that. So bone, renal stones, bone pain, and psychic. Psychic features. Parathormone is raised. Calcium will be altered. So phosphate will be altered. So something like features of primary hyperthyroidism. This is hyperparathyroidism of MEN syndrome 1 differs to certain extent from the primary hyperthyroidism because etiology are different. Here it is syndrome component. Otherwise, presentations are almost similar. So same features, whatever it is of hyperparathyroidism, abdomen groans, psychic moons, renal stones, and so on. So all those things will be there in hyperparathyroidism. Same features will be there. Sometimes they will have a palpable swelling in the neck, similar like a thyroid, but with high calcitonin level. If you do specific system, maybe radioisotope scan will be able to diagnose. Sometimes if specific venous sample, if you identify assess for parathormone very high, so along with that serum calcium and should be assessed as such. Multiple glands, two or more, all 4 glands may be known. That's the problem because if it is single adenoma, you'll be able to remove and come out and clear it. But many times all 4 glands are involved. Then all 4 glands or 3.5 glands you have to remove, and less than 1/3 gland you have to reimplant somewhere in the sternocleidomastoid muscle or brachialis muscle. But you have to constantly vigilant about this one. It may go for hyperplasia further, it may cause recurrence. So recurrence is high for the same reason which I have told. Serum calcium, parathormone, technetium 99 labeled system isotope scan. Very, very diagnostic of that. Neck imaging or investigations. Often it's very difficult to identify parathyroid. You know that parathyroid 1 to upper and lower, very close to the thyroid, very close to the recurrent nerve. So you have to identify all 4, you have to remove it and then clip it and reimplant part of it in somewhere in the sternocleidomastoid or brachialis muscle, depending on your choice, and so that you will be able to assess, eventually that area, if that goes for the hyperplasia to further removal of the part of removal of that. So the imaging, mainly ultrasound, sonology, high frequency ultrasound, good sonology will be able to pick up, and sometimes thoracic imaging, MRI, thorax, mainly radioisotope scanning. That is very, very diagnostic and useful to identify which part is involved. So 90% common. There is a point which you have to remember how much, often asked as MCQ. So second component is pancreatic islet cell tumor, currently called as pancreatic neuroendocrine tumors. Not uncommon. Remember, we come across very difficult to treat often. Second common association it is. Look at that. Second common, 90%. Gastrinomas are commonest. Again, MCQ question. In the MEN type 1 syndrome, present as Zollinger-Ellison syndrome with the multiple peptic ulcer, complex peptic ulcers, multiple peptic ulcer, gastric, duodenal, often jejunal ulcers in the typical of the Zollinger-Ellison syndrome. Gastrin, you know that Zollinger syndrome has got type 1, type 2. Gastrin level in blood will be very high. Insulinoma is common, again 30%. Gastrinoma, lipoma, other types can occur. There are multiple usually. There is again important thing because if you one single endocrine tumor is there, if you one nucleate, maybe through laparoscopy, that will be sufficient. Problem is there are multiple. Everything has to be removed, or sometimes you have to remove part of pancreas, distal pancreatectomy, median pancreatectomy. So it's like a major surgery. Surgical complications are there. If you don't remove, disease itself will be problematic. So a lot of, it's a major issue actually when they present with the mainly pancreatic neuroendocrine tumor as such, symptomatic one. And microadenomas are common. It's again difficult to identify where exactly it is there. So if you do endosonography, so we'll be able to identify, pick up all these things, can do a finish of this and confirm what exactly which type it is. Of course, biochemical assessment, gastrin level, insulin level, because many times they are functioning, gastrin level, insulin level, glucagon level, or other hormones which you are suspecting, then definitely it will be useful. You'll be able to identify what type it is. So for detail, pancreatic neuroendocrine tumor or endocrine tumor of the pancreas, you can read my SRB's manual of surgery, current edition. So detailed features are there, all glucagonoma, everything is there, pessary triangle, everything, insulinoma, its features, and each one is maybe a short note for you, and detail you should know, and especially for MCQ purposes they should know. So we can go through my manual, current edition, gives everything about detail about pancreatic neuroendocrine tumor or endocrine tumors of the pancreas as such. So this is the basic thing which you have to know when you discuss about the MEN Werner's syndrome, multiple endocrine neoplasia syndrome type 1. So pancreatic neuroendocrine tumor. So endosonography, MRI are very useful. Treatment is enucleation if it is single or multiple, visible, identifiable. Otherwise, pancreas may be distal, median, or head of the pancreas or whipples. So difficult to treat because surgical approaches are not easy. And recurrence is high. You may miss a small tumor because it is multiple. Again, recurrence can occur in spite of a major surgery. So surgery may be not successful in those contexts, and it becomes a futile exercise as such. So again, next is pituitary tumor. When you say somebody asks which pituitary tumor is common in MEN syndrome type 1 Werner's type. So it is anterior pituitary, not posterior pituitary. That's why it is important. Remember, again MCQ question, anterior pituitary. Prolactinoma is the commonest type. Again MCQ question. Secrets high prolactin. So features of high prolactin will be there. So you have to look for that. Second is growth hormone secreting tumor. Occurs in children. So all these things. So they will have giantism, high prolactin features in children, infancy and children. Around the age of 5 years, infancy, early childhood, it occurs very, very aggressive, often functioning, and again because of this one, a large micronodular MRI, CT will be able to see very nicely. Roger, you know that micronodular is usually less than 2 centimeter. Macronodular is more than 2 centimeters. So quite big it is, like this big tumor, more than 2 centimeter. So that is big one. Poor response to therapy. So whatever you do surgery, it may recur, it may cause further problem, it may cause if it is malignant metastasis, all those things. So serum prolactin, MRI head, treatment is transperineal pituitary surgery and radiotherapy is the treatment of choice. Of course, currently you've got a very good navigation system for brain surgery. Most of the well-trained, skilled neurosurgeons of current generation, they do using a navigation system exactly approach to transperineal route and remove those tumors precisely, properly, and almost near completely. So advanced technique and skill, current skill with the optical microscopy using, will be able to remove most of the tumor. So get a good, better cure rate rather than olden period because of the advanced technology and availability of these facilities for most of the neurosurgeons in all countries, including our country and developing countries. So navigation system is very useful in these surgeries, important, remember. So other tumors which are often not as common as parathyroid, pancreas and pituitary, but other tumors can occur. Remember, foregut carcinoma, other dangerous, life-threatening gastric bronchial thymoma. Adrenocortical tumors, commonly, invariably when it occurs in the MEN type 1 Werner's syndrome, they are malignant, which means naturally they are carcinomas. Thymic neuroendocrine tumors, not maybe rare but very aggressive, and sometimes they are malignant also. So these things often kill the individual rather than other components of the MEN syndrome, type 1 Werner's disease, Werner's syndrome, because these people are malignant. These are malignant, and these things are dangerous, often metastatic, and they are aggressive. So other tumors not that commonly associated, but once it associated, rather decide the outcome, mortality, prognosis, everything. That's often deciding factor actually. So need to look for these things even though it is not commonly associated. So do essential marker investigations in this patient. So family history is important because many times they are genetically, they are familial, autosomal dominant. Take up 50% of people, it runs in the family, remember. Biochemical screening in all these patients, PTH, calcium, prolactin, growth hormone, calcitonin for medullocarcinoma, thyroid, insulin, glucagon for endocrine. parathyroid for parathyroid adenoma. Prolactin, I said all prolactin is common, growth hormone. So all this investigation screening has to be done in all these patients once you suspect MEN syndrome. Imaging, MRI, CCT, head, neck, thorax, not sufficient if you do only abdomen. Thorax, head, neck, abdomen also, because adrenal tumors will be there. Endoscopy, radioscope study. So PET CT may be useful many times. Radioscope scan, especially systemic scan, and all those things will be difficult, easier to identify when it occurs parathyroid adenoma or hyperplasia. So genetic screening is also important because it runs in the family in many occasions. So management, I'm not going to detail all these things. When there is a pheochromocytoma in type 2, because type 1, we got 3 P's: pituitary, parathyroid, pancreas. There is pituitary, parathyroid, pancreas. But orderly it is parathyroid, pancreas, pituitary, because common parathyroid, second common pituitary, pancreas, then pituitary. So adrenalectomy you have to do because pheochromocytoma may be functioning, and you have to remove the adrenal, then go for the thyroid surgery, because functioning adrenal when you do thyroid may cause problem anesthesia wise. So adrenalectomy is the first thing you have to do in MEN2 type 2 syndrome, of course, not type 1. Total thyroidectomy again. Parathyroidectomy, all 3.5 glands or more. 1/3 you have to retain, implant into the sternocleidomastoid muscle or into the brachioradialis muscle. Then later you can put a marker tissue there, so that if it goes for a further hyperplasia, again slice it and remove it. And parathyroid estimation after surgery also important in this patient. Pancreatic endocrine tumor surgeries, endosonography is a must. And there are multiple difficult to manage sometimes: distal pancreas, median pancreatectomy, enucleations of multiple tumors, all laparoscopic approach. All those things are possible and used depending on situation, surgeon's choice, facilities available, high tech, robotic surgeries, high definition laparoscopic surgeries. Definitely we'll be able to identify, pick a small nodule areas. On table laparoscopy, on table sonography may have to do pick up where exactly identify the pancreatic and small endocrine tumors less than 2 centimeter microadenomas. So do an endosonography through laparoscopy on table. So I mark it and then enucleate it. All those things are available so that you'll get a better result, less chance of recurrence in these patients, which is definitely useful. Follow up with imaging, biochemical estimation. Biochemical estimation gives a clue. Further imaging, especially endosonography, MRI, markers, and so on, head CT, and so on. And genetic screening for family is important. Familial, because they need to, if genetic screening is positive, they need to monitor, and especially MCT, thyroid has to be removed because they go for a carcinoma, and look for a pheochromocytoma for regular biochemical assessment and imaging, and of course CT head if there is a small adenoma, pituitary adenomas at regular intervals during follow-up. So screening of family members is important, and accordingly you evaluate those people. So remember, organs involved, examine clinically all systems, because all systems, head, neck, abdomen, all systems may be involved. That's the point you have to remember. Because functioning tumors will involve everything, depending on the hormone which is secreted. So it's a hyper secretion of those hormones will cause problems. Functional presentation. So they have to look at that also. So those specific like diarrhea, tremor, hypertension, fluctuating hypertension for pheochromocytoma. Like that, so different parathyroid increase in that. So its features, parathyroid increase features, pituitary adenoma features, maybe in growth hormone, maybe Cushing's, all those adenocarcinoma tumors, Cushing's, or pituitary hormone tumors, growth hormone, gigantism, all those things. So depending on the which tumor or multiple tumors, so multiple presentation, multiple hormone presentations, and as a think and then look for those things. Biochemical assessment accordingly, same: pituitary, parathyroid, pancreas, thyroid, then adrenal gland. So the 5 glands you have to remember: pituitary, thyroid, parathyroid, pancreas, adrenal. 5 glands you have to remember when you look at the, or when you discuss about the, or when you think about the multiple endocrine neoplasia syndrome or MEN syndrome. 5 organs you have to remember. 5 endocrine organs. Imaging according to level, head to abdomen you have to see. Radioscope studies, especially for parathyroid, sometimes for adrenal. Therapeutic model, different model: total thyroid, pituitary ablation, adrenalectomy, pancreatic endocrine management, thyroidectomy, parathyroidectomy. So accordingly, so multimodality, multispeciality, neurosurgeons here, thyroid surgeons here, GI surgeons here, like that, different areas, different people. So you have to cover them. So multidisciplinary approach, many people has to get involved. Staged procedure, you don't do everything together, pituitary, other things. Do adrenal first, then thyroid and parathyroid, then maybe pituitary, like that. So staged approaches, not in a single sitting, you operate and treat these things, because a multidisciplinary approach, along with that, you need a, sometimes you have to give a chemotherapy, many times you have to think of radiotherapy, especially in the pituitary tumors, and you may have to do a targeted therapies also in many of these tumors. So all those multidisciplinary approaches we need, oncologist, radiotherapist, physicians, if there is a diabetic, they have to manage those, and endocrinologist, definitely, medical endocrinologist is important, because all these things are endocrine organs which is involved. So individual organ, how to behave, how to control those things. We need to need to have their help also. So follow-up accordingly, you have to do follow-up, pituitary, all organs you have to do, and assets, not single organ. So prognosis is not, especially 2B type, not good. Younger age group, not good. Functioning one, not good. Of course, malignancy, if it is, they're not good. If rare things involved, foregut, thymic endocrine tumors, if they are involved, again, prognosis worsens. So all these prognostic factors are important. Age, organs involved, malignancy, functioning one, all those things. So problems I already told, functioning was difficult. Different surgical approach, staged approach, time consuming, economy, costly, and final outcome we don't know. Recurrence can occur, parathyroid recurrence can occur, MCT can cause recurrence, pancreatic neuroendocrine tumor can recur, so pituitary tumors can recur. So all these things are the important. Anesthesia problems are there, and all these things. Major surgery, anesthesia complications. So all these things are the problems which you have to think of when you think of multiple endocrine neoplasia syndrome. So remember, ME1, one is Werner's syndrome. One is Werner's, not Werner's. I already given the reason. 2P, 3P it is, 3P. 2A is a Sipple's disease, SEPPILS, parathyroid, pheochromocytoma, and medullary carcinoma, MCT, medullary carcinoma, thyroid. 2B is Wegenman Forebase syndrome, or mucosal neuroma syndrome, pheochromocytoma, mucosal neuromas, marfanoid features, and medullary carcinoma, thyroid, 1P, 3Ms, mucosal neuroma, marfanoid features, MCT. So MP3. So otherwise, these three are different names: Werner's syndrome, Sipple's disease, Wegenman Forebase syndrome, or mucosal neuroma syndrome. One is 11 chromosome, 2A, 2B is 10 chromosome, because codons are different, 3, 4, 9, 1, 8, and involvement organs are different. 2B, parathyroid is not involved. So 2B but aggressive occurs in younger age group. So that is the point you have to remember. So all 5 organs you have to remember, you have to imagine and conceptualize and see what are the, so all these things are the MCQ questions. What are the organs involved? In ME1, thyroid and adrenal not involved. MN2A, pituitary is not involved. MN2B, parathyroid, pituitary is not involved. So like that you have to remember what all organs are not involved in each. That is maybe asked as MCQ question. Organs not involved in ME1 syndrome. So thyroid may be the I say answer which is not involved. So accordingly, so these are the organs involved in each type. Among total 5 endocrine organs are involved in total ME1 syndrome. So this table helps you to understand these pearls of the ME1 syndrome actually. So ME1, Werner's syndrome, 3P, parathyroid, pituitary, pancreatic endocrine tumors, MN2A, 2P, parathyroid, pheochromocytoma, MCT, MN2B, 1P, pheochromocytoma, MCT, marfanoid syndrome, mucosal neuromas. This is very nicely, everything it gives accordingly, and accordingly you have to evaluate and treat, manage with a multidisciplinary approach, multi-speciality approach, and regular follow-up, teamed approach rather, not individual approach, teamed approach. So very common entity which I asked as a short note for undergraduate, many MCQs are asked, rather confusing it. That's why this topic I have taken. MEN1 wormers, MEN2A sipples, MEN3A Wegenman Four-base syndrome or mucosal neuroma syndrome. So which organs involved in MEN2? 3P, pituitary, parathyroid, pancreatic, pancreas. Thyroid is not involved, adrenal not involved. MEN2A parathyroid, adrenal, medullary carcinothyroid. Pancreas endocrine tumors are not involved. Pituitary not involved. 2B, pheochromocytoma, adrenal and thyroid, medullary carcinoma thyroid. Of course, mucosal neuroma, other things are there. So morphonoid features are there in 2B, but they are aggressive. So organs which are not involved also you have to remember because MCQ question. Organs involved also you have to remember that because that is MCQ question. So specifications also important in this patient. Amyloid deposition can occur in the M2B, often asked as MCQ question, not others. So all those things are important to understand, and it is rather very interesting topic. So many organs, 5 endocrine organs involved as a system, as a syndrome. It's very interesting to understand, to learn, to academically enjoy this subject. And when you get to such patient, apply your knowledge and have a proper approach and treat the patient. That's why it is rather interesting, very important also for in MCQ. So you can always read, everything is there in my SRB's Manual of Surgery current edition. Lot of MCQs also there in the booklet given in that, in the current edition. You can always, how to examine this patient, you can always go through my SRB's clinical methods in surgery, extensively discussed how to examine the patient, abdomen, thyroid, parathyroid, head and neck, all those things. So you can apply that one. Of course, with the video of examination in each with the QR code it is there. So read my manual of surgery, read my clinical method of surgery, learn surgery in a better way. Of course, I request everybody to subscribe my YouTube channel. Already more than 500 MCQs are there, or 500 video lectures are there of different subjects, and live sessions already many things have there. Regularly it is happening. So join live session. Student will present the case, and many faculty, senior faculty discuss about the case like hernia, varicose vein, peripheral fluid disease, breast lump, thyroid, abdomen mass, swellings. So how you present, how we discussed in the exam, how you should write the case sheet. So everything is discussed. So you can go through that and learn surgery very well, both clinical aspect. Of course, daily MCQs are there. That also you can learn, go through that and learn. Clinical scenarios are there daily. That also you can learn. And of course, different instruments also there. Video switcherings are there. A lot of around 500 videos of different aspects of the surgery is there. You can always subscribe. Please subscribe my YouTube channel. Share with your friends and colleagues. And of course, please, again important, daily go through the videos because it is free, and learn surgery on day-to-day basis. Make your surgical knowledge better and optimum to face the exams in toto as such, as for CBME syllabus and NEET exams also, MCQs also. So students, I hope you have understood this lecture very well. Again request, go through my SRB Manual of Surgery, again go through my SRB clinical method of surgery, and my DigiNow JP, through JP publishers, lectures are there. Everything is covered so fully. Clinical examination, all chapters, specialty, urology, neurosurgery, cardiothoracic, everything. That also you can learn with my DigiNow lectures. 1 year you can subscribe, so that 1 year entire thing lectures you can go through that. All topics are there: clinical surgery, operative surgery, specimens, then all topics A to Z, general surgery, thyroid, breast, endocrine, then gastrointestinal surgeries, urology, specialties, everything is covered, with including clinical aspects. So you can learn surgery in a better way, along with my clinical surgery manual and clinical methods in surgery with the YouTube channel. You can surgery entire thing with this. So again request, go through my DigiNow, go through my manual, go through my clinical methods, subscribe my YouTube channel to learn surgery proper way, better way. Students, I hope you understood this MEN syndrome topic very well. Thank you so much.